I wanted to go over the planum temporal and the planum polar again because I also wanted to discuss the surgical relevance of why preserving planum temporal is very significant and what is going to happen if we have lesions in here. Let me see. Let's go back. So you all remember the anatomy so far, right? I do not need to repeat it. Okay, moving on. We have the planum temporal here. Let's see the image first so that we can come back to the discussion again. Let's draw here. This is the superior temporal gyrus right here. And this is the same continuation. They have just divided it into the anterior segment and a posterior segment. Then when we retract the frontal operculum superiorly and part of the parietal operculum as well, we see the flat part here, which is the planum polar, and on planum polar we have the MCA running, whereas posteriorly we also see the Heschel's gyrus, which was the primary auditory cortex, right? Then we had the planum temporal right here, and planum temporal was associated with language comprehension, etc. Because right around here, we also have the vernix region. We discussed this very thoroughly yesterday, that part of the superior temporal gyrus and part of the angular gyrus and the supramarginal gyrus something here, because this is retracted, so it's difficult to locate. Then all of them make up the vernix area, and planum temporal is obviously in close association with it. So any lesion here in the posterior temporal lobe, or if you end up damaging this region during the surgery, then the patient is going to have some neurological deficits. Which neurological deficits, we are going to discuss them later on. Clear all of this and go back to the comparison table. So planum temporal, which is posterior to Heschel's gyrus, it is involved with the language comprehension and the auditory processing, because we remember that this region here is associated with the primary auditory cortex and the language area. So obviously planum temporal, any lesion, any injury here is going to affect the language comprehension. Then we have this strong left dominance in the planum temporal, which is not a feature of planum polar. And if there is any lesion here, then patient can have dyslexia, schizophrenia, and stentric. Whereas planum polar is anterior in front of the Heschel's gyrus, and it is associated with the musical perception. And usually it is a right dominant because we know that the right side of the brain is associated with music, with arts, etc. So planum polar is usually bigger on the right side. And if this ends up damaging, then there is social emotional disorders, auditory agnosia as well. What ends up happening if there is a dominant planum temporal lesion? Vernix aphasia, because it is in close communication with vernix area, patient is going to have vernix aphasia even if you do not see the lesion outright on the language cortex that you can see on the lateral surface. Where is the planum temporal? It's on the superior surface of the temporal lobe. So it's hidden under the sylvian fissure, right? If you do not see a lesion on the lateral surface of the brain, but the patient has vernix aphasia, this means that there could be a lesion somewhere around the planum temporal. If there is bilateral planum temporal lesion, then there is pure word deafness. Patient is going to hear the sound, but they cannot understand what sounds are those. They cannot, decode this speech. If planum temporal is injured on the non-dominant side, or if there's a lesion on the non-dominant side, then the patient is going to lose perception of the music. Whereas if a dominant planum temporal is the epileptic focus, then patient can have auditory auras and language arrest during the seizures. Am I clear so far? Am I audible?
Yes, sir.
Yes, yes. You
Yeah,
are.
yes, madam.
You people
Audible.
have been awfully quiet. In fact, everyone is muted. Thank you so much for that, though. Um, let's proceed. So then we have the entorhinal cortex. And as a neurosurgeon, you might not think much of the temporal lobe apart from the superficial structures that we know of. But entorhinal cortex is really, really important. It is a small area in the middle temporal lobe, but it serves a lot of functions. I discussed yesterday that it is the cortex for olfaction. It is part of the primary cortex, the primary olfactory cortex. But apart from that, it also acts as brain's GPS. It works for memory, for navigation, for time perception, for visual spatial orientation, and it is one of the first areas to get affected in Alzheimer's disease. So, entorhinal cortex is the brain's GPS. It's also part of the primary olfactory cortex. We discussed this yesterday. I'm just repeating it today. And why is that? Because it closely works with both the memory systems and the smell systems. So, the thing that happens when you smell a certain perfume or a certain smell, and it reminds you of someone or it reminds you of a specific time or a date, then that is your entorhinal cortex working. And it creates timestamps is a very interesting word. Entorhinal cortex creates timestamps. Your brain perceives a smell, entorhinal cortex registers it, and then also puts a timestamp on it. Okay, this person felt this smell at this date and this time. So what ends up happening is once you smell it again, there will be a familiar association and it will bring back some memories. Sure.
Madam,
Yes.
madam, this entorhinal cortex in dogs, like they smell and remember their owners after 6 months, 7 months. I think there and dogs and all they will have a very strong entorhinal cortex.
Yeah, that's right. Dogs have a very strong entorhinal cortex. Hence, they have a very enhanced sense of smell, and they can mark a person with their smell. So yes, animals have certain regions of the brain which are much more developed than the human brain.
Yes,
I think
madam.
neuroscience is just as fascinating as neuroanatomy and neurosurgery. So these
Yes,
are the areas where we have the entorhinal cortex. It's 34 and area 28. You can see that this is the region, this is the medial portion, right? So uncus is going to be here, uncinate fasciculus is somewhere going to be here, and the olfactory striae, the striae that we did a few days back, the medial and the lateral olfactory striae. So all of these are in connection here, and the area numbers, you need to remember that 34 and 28. Let's move on. So the temporal horn is a small structure, but it is the gateway because you can use it as a corridor for for reaching the mesial temporal lobe structures like the hippocampus, like the amygdala. So I think I have that picture. Let me go back. Hmm, I'm not sure if it was in this. Yes. So if you see the surgical approaches to the temporal horn, then what ends up happening is, let me draw here. This is the middle temporal gyrus. We discussed that a few days back. And via the middle temporal gyrus, you can access the temporal horn. And via the temporal horn, if you go deeper, you can access the hippocampus. You can also access the amygdala. So to reach the mesial temporal lobe structures, you can use the temporal horn as a corridor. So we need to know the anatomy and the boundaries. Let's go back. I forgot that I have this image here in the presentation as well. The roof is made by tapetum of the corpus callosum. Tapetum is a small white matter band, which is a part of the corpus callosum. How is this? Okay. So tapetum is a part of corpus callosum. It turns around the roof. Then we also know there is Mears loop, which is the optic radiations. We discussed them yesterday. And then on the floor, we have the hippocampus. Anteriorly, we have the amygdala. Laterally, we have the thalamus and the tail of the caudate nucleus. Unfortunately, I could not find a very good picture that depicted the caudate nucleus tail, because caudate is superior to temporal horn, but its tail goes down and it contributes to the lateral wall. Then we have the choroid plexus. Choroid plexus runs along the boundary of the femora and fornix on the medial wall. Let's move to some illustrations. It's the same picture, but you can see that the tapetum is here on the roof. And over the tapetum, we have the optic radiations. I think I would just draw it here. So this light green structure is the tapetum. And on it, we have the optic radiations, which are also called the Mears loop. But you cannot see the tail of the caudate in here. And I don't think the thalamus is visible here either. Let's move to the next illustration. This is an illustration because on dissection images, on the cadaveric images, it's really difficult to identify such small structures. But let's draw it here. This is your temporal horn. I'm going to code it blue so that you remember that there is water here. And then you can see what is happening here. On the medial side, we have the hippocampus, which is also making the floor. Collateral eminence is going to be an elevation inside the temporal horn, and the roof and the lateral wall is going to be contributed by tapetum, and then optic radiation, and in some sections, there will be cuts of inferior longitudinal fasciculus as well. This is the junction of the femora, and the choroid plexus is going to run somewhere here. Let's move to the next image. This is a cadaveric image, and you can see the structures now, but obviously they are not as clear as an illustration. We have the choroid plexus. The choroid plexus runs along the femora and the fornix junction on the medial side. Then we have the dentate gyrus. Dentate gyrus is also part of the hippocampus, hippocampal formation. Then we have the temporal horn roof. The roof has been cut. I don't think there is any other important structure visible here, but you can also see the same on this other image. This is uncus, and this is the posterior segment of the uncus. This is the anterior segment of the uncus. So what we see superiorly, if we dissect it and open it up, we are going to find temporal horn underneath it. This is a coronal section, and it's a good image because it does tell a lot of important relations. You can see the basal vein of Rosenthal going here, which is a very important venous drainage for the temporal lobe. This is the deeper venous drainage. The superficial venous drainage we have already discussed. Then you can see the collateral eminence, which is the projection of the collateral sulcus on the inside of the temporal horn. You also see the choroid plexus. And if we cut this open, we are going to find femora somewhere here. On this lateral side, there's going to be the tail of caudate and some portion of the thalamus. Then we have the vascular supply of the temporal lobe. Interestingly, half of the temporal lobe is supplied by MCA and half of it is supplied by PCA. So it depends which portion of the temporal lobe has a stroke. If it is MCA, usually it's going to be slightly anterior, and the lateral portions. MCA supplies via M2, M3. It supplies the superior temporal gyrus, the middle temporal gyrus, and the inferior temporal gyrus, but the lateral surface, not the orbital, not the inferior surface. Then we have the anterior choroidal artery, which is an ICA branch. It supplies all the mesial structures, the amygdala, the hippocampal head, the optic tract, the posterior limb of internal capsule. Then we have PCA. PCA supplies all of the inferior surface, the parahippocampal gyrus, and the fusiform gyrus. P2 also supplies the body and the tail of hippocampus. So if there is a PCA infarct, patient might have the memory deficit if the temporal branches are involved via P2. Whereas if the MCA is involved, then the patient might have auditory neurological deficit. The venous drainage is very simple. Superficial venous drainage is via vein of Labe. It's the anastomotic vein, the inferior anastomotic vein. It drains into transverse sinus, and injury causes the venous infarction. We have discussed this very thoroughly. Then the deeper venous drainage is via basal vein of Rosenthal, drains into the great cerebral vein of Callan. So you can see the deeper venous drainage here. We have the basal vein, and the basal vein goes back. I can see here. It drains the deeper portions, the medialmost portions of the temporal lobe, and then it goes back and it drains into the vein of Callan, and then from the vein of Callan, it goes into the straight sinus. So the venous drainage is going to be two ways. Vein of Labe. From vein of Labe, it's going to be transverse sinus, and from basal vein, it's going to be vein of Callan and straight sinus. Am I clear? Am I audible?
Yes, ma'am.
Yes, ma'am.
Okay. So anatomy can be dry. Anyways, this is the last anatomy session for this week. So we will be back to the clinicals. Apparently, you all like tumors much more, but anatomy is our GPS. We cannot function without it. So the surgical relevance, why did we spend 2 days on temporal lobe? We need to know what happens if vernix area is right easy. It's receptive aphasia. Patient is going to have the word salads. They are going to talk, but they are not going to have any idea what they are saying. So if the vernix area is damaged, we have receptive aphasia. How do we avoid it? We map the vernix area with the awake craniotomy. Whenever there is language cortex involvement, the preference is always awake craniotomy if the patient is cooperative and coordinating. Even if you cannot do awake craniotomy, functional mapping will still be ideal. Then we have the Mears loop. How do we protect the Mears loop? We stay 3 centimeters, we stay within the 3 centimeters from temporal tip, but Mears loop is slightly deeper. So if you are taking the superior temporal gyrus, the Mears loop is not going to come in the way. Then we have the anterior choroidal artery, hemiplegia, hemianopia, and hemihypoesthesia, hemisensory loss. So it's 3H. We have to identify, we have to preserve. It's a very critical artery and we cannot risk losing it. Then we have vein of Labe. We know that it's going to cause temporal lobe venous infarct, and it's very critical during the retraction and during the terional and the subtemporal approaches. Uncus and hippocampus is straightforward. Memory loss is going to be there. For amygdala, patient is going to be emotionally labile. This means patient is going to be emotionally unstable with very intense reactions at times, and at times no reactions at all. And this is used as the landmark for entry into the temporal horn. Then we have fornix. Fornix, if the fornix is damaged, this means patient is going to have anterograde amnesia. What do we mean by anterograde amnesia? We mean that the patient will not be able to form any new memories, and you need to preserve it during the transchoroidal approaches. There it is. So even though anterior temporal lobectomy is a separate session, because it's a topic of its own, it deserves its own time. It's part of the functional neurosurgery, but I wanted to include the margins because it is one of the most commonly asked questions. For the dominant lobe, the posterior limit is anterior edge of planum temporal. We did discuss it yesterday. On the dominant hemisphere, the margins are going to be 3.5 to 4 centimeters. And on the non-dominant side, you can go slightly back, 4.5 to 5.5 centimeters. But there are a lot of variations when we talk about the anterior temporal lobectomy. What are the variations? For example, there are some authors that say that you have different measurements for different gyri. For example, we have the superior temporal gyrus, we have the middle temporal gyrus, and we have the inferior temporal gyrus. So if you're staying on the dominant side, let me draw them so that it's easier to. This is the superior temporal gyrus. Then we have the middle temporal gyrus. Then we have the inferior temporal gyrus. So we can have separate resection limits for all these three gyri because their importance and their eloquence is very different. On the dominant side, superior temporal gyrus is your auditory area, so you cannot go behind 3.5 to 4 centimeters. So I'm going to mark it here. It's marked as. But for the middle temporal gyrus, you can go 1 centimeter behind. And for the inferior temporal gyrus, you can even take the liberty of going even further. So for middle temporal gyrus, it can go up to 4 to 4.5 centimeters. And for inferior temporal gyrus, it can go up to 4.5 to 5 centimeters. If you're an exam candidate and you are going to appear in an exam, never mention these separate boundaries until and unless someone asks you specifically. Otherwise, the standard, the most sought after boundaries are these 3.5 to 4 centimeters on the dominant side and 4.5 to 5.5 centimeters on the non-dominant side. These are only discussed once your OSCE station or whatever whatever the topic you're discussing is specifically related to functional neurosurgery, and someone is asking you the boundaries that what do we do if the focus is slightly posterior, etc., etc. So when variations are discussed, only then you can tell that with middle temporal gyrus and with inferior temporal gyrus, you can take slightly more liberty. Let me show you the next slide. Now you can see different types of the anterior temporal lobectomy here. You can see how on the superior temporal gyrus, they have only resected the tip, whereas for the middle temporal gyrus and the inferior temporal gyrus, they have taken quite the liberty and they have still taken it out. But with middle temporal gyrus, there will be the risk of injuring the Meyers's loop. That's all for temporal lobe anatomy. It's a wrap. But since we have 5 minutes left, the session is open for questions or any discussions, any feedback that you want to give.
Even in antetemporal lobectomy, we can also include amygdalohippocapectomy also.
Yes,
We
there are
used to-
multiple variations. That is why I mentioned initially that when we say anterior temporal lobectomy, it usually has a lot of variations. It also depends for what reason you are doing it.
For
Where is the
surgery.
cause? Yes. No. Anterior temporal lobectomy can have multiple indications. One of them is for epilepsy. There are other indications as well. So there are surgeons who will include the hippocampus, who will include the amygdala, and then there are surgeons who will only do this lateral portion. So there are multiple variations. They even have different author names, and I was going through them, and I thought that probably we will have a separate session on them once we discuss the functional neurosurgery.
Yes, sir.
Is the anatomy clear? Do you have any
Yes, ma'am.
questions on the sylvian, even on the sylvian or the temporal lobe? Because it was, a single module. They are deeply connected. You cannot separate sylvian and temporal.
Madam,
Yes.
how would you avoid Meyers's loop damaging anterior lobectomy?
I'm sorry, your voice is not clear.
How would you manage the Meyers's loop damage in anterior lobectomy to
We do
avoid
not. We do not take the Mayer's loop during the
Yeah.
anterior temporal lobectomy.
But you said that 3 centimeter, if you are going to about 3 centimeter, greater than 3 centimeter.
Then we can do a preferential surgery, as in we can develop this plane between the Mayer's loop and the cortex that we are taking out, because Mayer's loop is a white matter tract, right? We have to take out the cortex, the gray matter.
Oh,
It's the same principle, the way we do the subpial resection for the MCA. Once we are taking the planum polar, we do the subpial resection. So we create two boundaries between MCA and the cortex, the arachnoidal layers of the MCA and then the pia mater as well. So we leave a small margin and do the subpial resection. I believe it stands true for Mayer's loop as well. Do we have any other questions? No? Okay, everyone. Thank you so much. This is a wrap. See you all on Monday, inshallah. Thank you so much.